Pleasure to meet you all or see you all today and grow your comfort with Nimbus. As I understand that many of you are recently looking into adopting it in your practices. And my understanding is, as many of you are active users for CoolLeaf. And so hopefully this presentation will help kind of give you some insight into my experiences, give you some opportunities to ask some questions regarding application of using these new needles in place of the CoolLeaf, and then get you all comfortable and basically answer any questions that you have. I'm gonna pull up my slide deck and then share the screen with you all here. So as Tammy mentioned, when I was at fellowship at HSS, Avanos was doing a study site. We were one of the study sites for their, well, it wasn't Avanos then, but CoolLeaf we were a study site for CoolLeaf and establishing it as it started to kind of roll out in terms of their national advances. And then as I adopted in my practice, had used CoolLeaf for a long time, trained for them, and was one of their KOLs, and then was introduced to Nimbus when it was available and started using it for a variety of reasons in my ASC, and have now kind of fully migrated and adopted use of Nimbus 100% for all of my uses for large volume RFA. And so as many of you are current CoolLeaf users, you're all aware of some of the advantages, especially in terms of patient satisfaction and the longevity of the response that you are getting with large volume lesions. Nimbus is a really exceptional way to accomplish those same large volume lesions, in my opinion, with a little bit of a less cumbersome technique, and also a little less cumbersome for your staff in terms of throughput as you're seeing patients. So we'll go through the overview of what Nimbus needles are. We'll talk about the geometry, and then, as I said before, most of you know the value of large volumes. And then we'll talk through some specifics to the technique for cervical, lumbar, and thoracic. I am super casual when it comes to these presentations, especially on Zoom. I know that some of you probably have time constraints. So if you do have a question, I don't mind you raising your hand or interrupting when I'm speaking, we don't have to wait until the end for questions. If you have a question that's pressing, I am happy to address it as we're going through this presentation. So first off, the design of Nimbus, a couple key points. So it's made up of, in essence, it starts out looking like a normal introducer cannula. It is an insulated cannula with an active tip. And at the end, which would normally be the hub of the needle, is attached to the spin collar, which as you rotate that spin collar, it deploys these stainless steel tines. These are made of surgical grade stainless steel, and they are deployed. And then also notably, they collapse. So if you were to pull this against the tissue, they'll actually collapse on themselves and be able to be cleanly pulled out of the patient. Due to the geometry and the way that these tines are created, as you can see, there's some forward projection of the tines that provides this kind of pear-shaped lesion that tends to be approximately 601 millimeters cubed, tends to be a width of 10 millimeters by 11 millimeters in depth. Most of the lesion is going to be and this is relatively intuitive, is going to be projected towards the direction of these tines, and also at the base where those tines are widely disseminated. Because of that, if you imagine how the physics of placement of a needle on os is, these needles are best perpendicular to their target rather than traditional cannulas that require that 10 millimeter active tip to create their lesion size and are better off parallel. So just a notable piece. Another notable piece, and I think this is depicted in a slide down the road, but if you're familiar with CoolLeaf has a significant amount of forward projection, which in certain areas can be kind of more risky or concerning. The Nimbus needles don't really project past the tines of the needle, so there is no forward projection. Keep in mind that the tines do project past your original needle tip. When you deploy these stainless steel tines, often it will push you off of os a little bit and leave that push backwards the needle tip, but there is no forward projection past the radiographic evidence of the tines. This just compares, as I was saying previously, that the perpendicular approach is best. This kind of compares some differences between your standard cannula shape as well as the kind of pear-shaped lesion that is created with Nimbus, and why that perpendicular placement does make the most advantage of the geometry of the needles when those tines are deployed. Just a comparison of different types of needles in terms of their size and of their lesion. So when you look at, first of all, comparing Nimbus to cooled radiofrequency ablation, we have standard placement of our, in terms of our time and settings for our temperature, whereas CoolLeaf, as we know, takes advantage of that heat sink that's created by the room temperature water. And so the target settings, machine settings, tend to be lower for a longer duration of time. You're able to use Nimbus with your 80 degrees Celsius for 90 seconds and create a lesion size of 601 millimeters compared to the categorization of CoolLeaf, which is 595 cubic millimeters. This is, of course, in comparison, as we know, our lesions tend to get larger as we use a larger needle size. So comparison of standard monopolar electrodes, you can see as you move from 20 gauge to 18 gauge to 16 gauge, you do get a variation of lesion size. But even with very large 16 gauge needles, your Nimbus is still exceeding those by about 3 times. Looking again at the lesion shape, this is just another schematic kind of showing you the difference of the lesion volume as well as shape. So with the CoolLeaf shape that you see on the bottom of this slide, you can see there's that forward distal projection of about 5 millimeters past the active tip, and then a generally round shape as opposed to the pear-shaped lesion that Nimbus creates. Now, remembering this picture down the line when we start talking about techniques, because I'll talk to you a little bit about how I use this to my advantage when I'm placing these needles in patients to help guide, especially in cervical, to help guide the placement of that lesion and the performance of the burn. Again, looking at the visual on the lesion shape, showing that almost 45% of that lesion is distal projection with CoolLeaf, which essentially means that in function, because many of us are still taking our needle even with CoolLeaf to os, and then deploying that, well, with CoolLeaf, when you change the introducer, you end up having a gap that's created that accommodates for that forward projection. In effect, you're really getting a more active, much larger lesion, even with Nimbus, which is why in my patients, I probably see even better effects than I was when I was using CoolLeaf. So in terms of just a summary of what we talked about, due to the way that the mechanism of the deploying of the tines are, you'll want to click the anchor point so that those tines are fully deployed, which allows you to deposit any local anesthetic, or if you're a steroid user, down the barrel of the beam prior to injecting or prior to stimulating or lesioning to fully deploy those. We're setting our settings very similarly to traditional RF with 80 degrees Celsius for 80 to 90 seconds. With our bipolar, we expand that to 150 seconds to help make that lesion. And then again, we're usually using a perpendicular or down the beam type of approach. So now moving into just a pause, I guess, of does anyone have any questions about the geometry of Nimbus or any of the things that we talked about so far? So one of the places—
I just had a quick question, so sorry.
Absolutely, go ahead.
Nick Beatty, thanks for your talk so far. Are you referring to a parallel down the beam hub view or a perpendicular approach?
So a perpendicular approach, and you'll see my pictures in a moment of how that is accomplished. But in general, I either in practice will do a very similar approach, just with slightly steeper angles to a traditional RF approach, or I will do a true perpendicular where my needle ends up perpendicular to the target, depending upon the structure. And so when we go through, especially the cervical pictures, we can talk about that a little bit more. But essentially, I try to make sure that my tines are deployed so that they're on the os rather than away from the os or parallel to the os, if that makes sense. So whenever I land on bone, the tines are on os, both together rather than next to them. So we're all familiar with our cervical anatomy of our facet joints, and the target being that waist of articular pillar. I know that when I was training for COOLIEF, the approaches that I was taught in fellowship were always what I would consider traditional radiofrequency ablation approaches, which is with a patient positioned prone, and advancing the needle from posterior to anterior, to place that needle on the articular pillar. What COOLIEF was training and what I believe in this 10 years, as they've kind of broadened their breadth, is a perpendicular type of lateral approach where, due to that forward projection being somewhat concerning, especially in the cervical spine, they would train new physicians with patients laterally on radiofrequency ablation. I want to just make a disclaimer as I continue to talk, as even when I was doing COOLIEF, I never did that approach. That was not an approach that I ever really employed in my practice or felt comfortable with. Every approach that I've ever used with cervical radiofrequency ablation has been with the patient prone and advancing the needle posterior to anterior, along that articular pillar. And so going back into our, further discussion, which many of you, again, are employing already in your practice. I use cervical RFA a lot. I have a very heavy whiplash injury motor vehicle accident practice. There are many patients who have some sort of underlying facet arthropathy that has never caused them any pain. Maybe they're in their early 40s, then they get rear-ended, and then they have terrible axial neck pain. So it's a treatment that I'm employing frequently in my practice, and I find super helpful to give them improvement of the pain. So cervical radiofrequency ablation, I tend to use a different type of positioner than is depicted here. These photos are from an upcoming book publication. But in my office, I tend to use a blue, which we're probably all familiar with too, or have at least seen, a blue patient positioner where the forehead goes on a support structure, and the chin kind of is positioned in a flexed position to support the head fully. The head I keep in a neutral position. There are some providers that do prefer to rotate the head slightly away from the target areas. Personally, that is not my practice, but that is something that people employ if patients require that for comfort. In terms of the target, this is showing an upper cervical target on the third occipital nerve, or the TON. This is a AP position showing those tines, and this kind of shows a little bit more that the needles are perpendicular to the waist of that pillar, and you can see the tines in the x-ray here deployed kind of up and downward on the radiographic image. And so I will identify the lateral mass of the third cervical vertebrae, and then I will advance to an area just above the waist to target that C2-3 interface at the facet joint complex. With that complex, like that joint lucency usually between my tines in the lateral position, which I have here, you can see those tines crossing with the lucency of that joint between those tines. In this case, there's probably some parallax where that tine, the tines are not fully perpendicular to the fluoroscopic view. That's why they look a little bit more collapsed in this picture. And so when you're using these needles, you can see that as you rotate and change the rotation, you might see the tines appear on the imaging to go and collapse. But that's not actually in vivo collapsing. It's just an anomaly with the radiographic image. But so I'll place my needle down to os. I'll deploy the tines, which you can see here again, crossing that lucency between the C2 and the C3 vertebral bodies, and then I'll deploy those tines. When you deploy these tines, the needle often pushes back. So I'll often have an initial image where my needle tip is in the centroid of our articular pillar, which is the general target for the posterior to anterior projection of the needle. But then when I deploy those tines remain at that centroid, but it will push my needle slightly back with the force of that stainless steel. Unlike some other companies that have nitinol, which is a very flexible structure, that they'll create tines. These are truly surgical grade stainless steel tines.
Can I ask you a quick question?
Absolutely.
This is Court Miller. Can you go back one slide?
Yes.
So this is kind of, like you said, kind of normal trajectory, especially that right picture of where you do like a regular RF, kind of going parallel with the edge of the lateral mass there.
Correct.
So do you have the tines on, like, in terms of which side you have the tines, like how on the nimbus needle it has that white line, so you'd have that kind of facing the bone then, so the tines are like up against the os side, right? Not the thick part of the shaft, like up against the bone with the tines sticking out. You want to always have the tines up against the bone then.
I prefer to make to take advantage of the way that the tines project so that they're bending back towards os. So then I know that I'm hugging back towards os. So yes, I would turn the white line towards like medial on the patient's body. Now, as we all know with cervical radiofrequency ablation, there are some people that have really, really significant arthropathy. And sometimes, even when we're using conventional needles, it's hard to advance to a centroid location due to that kind of bony overgrowth that isn't necessarily apparent on imaging, kind of that, I don't know, I call it just a feature of arthritis. But and in that case, sometimes if I can't deploy the tines medially, I will rotate and deploy them externally and take a look at my image to make sure that they're not too far away from the articular pillar, and they won't be usually. But that helps me get my forward, motion so that I'm closer to that centroid of the articular pillar. And so I use these tines to my advantage many times.
Yeah, and then do you normally advance it kind of in a straight EP like approach, or do you oblique slightly and come at the pillar a little bit, where you're kind of have a little bit of an angle on it coming in towards the bone, or are you just kind of going straight parallel with the side of it?
I'm usually coming a little bit towards the bone. And actually these two pictures, I don't know if these are my pictures. This one on the left especially doesn't look like something from my like the way that it's labeled doesn't look like something from my x-ray, but you'll see my pictures where I have, a lot of times I'll have it angled slightly where my hub is slightly, inferior and lateral to the target so that there's a slightly angling towards the target.
Gotcha, thanks.
Absolutely. These are my pictures. So I like these pictures because first of all, you can see, in this level, you have pretty good, well lined up fluoroscopic image, right? But in real life, people have some sort of listhesis or switching. So in this case, it was harder for my x-ray tech to line up the inferior level. But I use the planes of, the lined up level and the feature of the fact that this will deploy backwards. So I will line up those needle tips. And then when those tines deploy backwards, I know that I'm in a safe location because there's nothing moving forward where anteriorly I might end up in places that I don't want to be. The contralateral oblique is also something that I use, especially with my epidurals, but sometimes I'll find it advantageous to use my contralateral oblique image to confirm, especially in the neck, that I have located where I want to locate. And so you can see as you rotate to the contralateral oblique, creating footballs out of the lamina, you can see those tines deployed on that articular pillar right near that waist area. This kind of talks about what I was discussing before. Sometimes you'll encounter resistance to the deployment of the tines. And if you slightly move that cannula ventrally or rotate the cannula, you can be able to deploy those tines when you weren't otherwise able to. So this is just another picture of the third occipital nerve and C3. In this spot, the needle tines are a little bit higher and don't fully straddle that lucency. This location is also acceptable. I wouldn't I would always want at least one of my tines to be in that lucency or below area. This is an example of kind of a smaller patient on the right, where really the deployed tines almost engulf the whole vertebral body, which obviously this burn will very well address any of her, the location of her medial branches.
One other quick question. If you're
Absolutely.
doing bipolar, like, I don't know, like, let's say you're doing a thoracic and you want kind of a big one right on the tip of the transverse process, do you put the tines from the two needles with the tines in the middle, like facing each other, or do you put the tines facing out?
So for bipolar, you'll want to put the tines facing each other. I will say that for these lesions are big enough. I have personally never used bipolar for the thoracic. I think I have pictures in here for my thoracics.
Yeah, I
I
guess I'd use it more for like SI or geniculate, maybe
absolutely.
not so much thoracic. I was just trying to think of an example, but just bipolar though, you'd want the
Yes.
tines facing each other.
Yeah, so for like sacroiliac joints, you would place your needles usually next to, your dorsal ramus, your S1, your S2, your S3. You would do an initial bipolar lesion with the tines facing each other at, say, dorsal ramus and S1, and then you'd rotate S1, face it to S2, have S1 and S2 face each other, and then so forth with S2 and S3. And so you're able to do that, unlike with Coolleaf, where you're doing the 9 o'clock, 3 o'clock approach, and you're having to move and relocate those needles as you go with really multiple burns for the Coolleaf process. You're able to do it with just the 2 and sometimes 3 burns, depending on if you include your S3 or not with the bipolar. And the bipolar images, I'm not sure if they're in this slide deck, but the bipolar images of the burn that is created with Nimbus and bipolar they're really striking. It's very effective for SI joint. This is just some more pictures of the cervical technique. I think that as I've taught both with Coolleaf as well as with Nimbus, cervical and large volume tends to be the place where people have the most questions. And I actually prefer to use Nimbus for my cervical RFs at this point after using Nimbus for 3 years than even traditional radiofrequency ablation, because I noticed that patients get actually less neuritis or less of the sunburned kind of funny feelings, which I actually think recent data has shown that that's actually due to underburning the nerves. But also the comfort has just increased for me so much. I remember telling a rep long ago when I was using Coolleaf, like, I'll never use that in the cervical spine. But then I really adopted the use of this in cervical spine and again, really prefer it. These are just some more pictures of our cervical anatomy varies so much, and our ability to get really good images varies so much. And so I just wanted to include lots of different cervical images that resulted in good results for the patient and safe results for the patient. And so on the left, you see here, those tines pointing towards the articular pillar. And I think that shows them projecting away pretty well towards that pillar. You can see, third occipital nerve over the joint lucency, your C3 and your C4. And then likewise in the lateral, a similar picture where getting a good view on both C3 and C4 was difficult, but able to kind of accept these images due to the way that the geometry of the lesion deploys. And then here, someone who's pretty arthritic. In this case, this is an example where I physically couldn't get my needle closer to the articular pillar in the AP view, but I was able to deploy those tines closer due to whatever kind of callus overgrowth was preventing me to access what I would consider the true articular waist. Yep. In this case, this is at level C4-5. It's just, more of the same at the waist of the articular pillar. Some more pictures showing the advancing of the needle to that centroid and deployment of the tines. So if you notice on this one down at C5, those tines are more anterior. My needle point is at the centroid. I don't know the situations of this needle placement. I might try and pull it back a little bit to get more the tines kind of in that back third. Are there any questions about these pictures? There are just more pictures of the different locations. This is another contralateral oblique showing the placement of those needles before the deployment on the waist in the contralateral oblique view. So often people will ask, like, you know, what does the contralateral oblique view look like, you know, for radiofrequency ablation? And so wanted to include some of those as well.
So Dr. Blake, there was one question in the chat.
Yeah.
Uh,
A patient reported skin dysesthesia, numbness in right lateral aspect of his neck and ear following his right C567 RFN. So was this a person who had large volume radiofrequency ablation?
I'm not sure because somebody else did the case, and so this was a referred patient to me, not happy with the dysesthesia that happened post RF, but was happy initially with the response to the injection.
So in my experience, when I've had patients, and I have occasionally, maybe one or two in a 6-month period might get what I would probably consider this as like the skin dysesthesia kind of on the surface of the neck. My experience is that it has happened for me most commonly with traditional radiofrequency ablation in the neck. And I often think that it's when you cannot advance it far enough on the articular pillar. But the treatment that I usually give people is topical lidocaine, and I prescribe Lyrica. I've never seen dysesthesia persist as long as the results of the radiofrequency ablation, meaning I've never had an episode in my own practice of someone describing the sunburn feeling, the dysesthesia feeling, or the numbness on the skin that has actually lasted longer than the results of the procedure. So usually, like, it might last for 6 weeks or 8 weeks. But I've never seen it persist longer than that in my experience. But my options that I would use would be to give him lidocaine if he has that topical lidocaine. And in terms of technique wise, during the procedure, I would look at the I would try to get my hands on the procedure note and see what kind of thresholds, if they did sensory. Sometimes you might see this when people have very, very low sensory thresholds in traditional RF.
Right. So in this case, the procedure was done 8 months ago, and he had good pain relief for the initial 3 months with like 70% relief of his pain. I'm sort of wondering, because we are reimbursed for a pulse radiofrequency as well, I'm thinking between, should pulse help versus should I do a repeat burn and create a good lesion? So in that regard, I was thinking, how would you proceed?
I would do a repeat burn before I would do pulsed RF. I don't think you're going to get excellent results of the facet joint treatment with pulsed RF alone. Now, some people will pulse before they do a traditional RF, and I think that sometimes can be effective in patients that are prone to dysesthesia. There's a case report or a literature series of patients, and again, this is not specific to Nimbus or with, and I haven't done this with Nimbus, but with traditional RF, for people to do like a 60-second pulsed RF before doing a lesion, and that there's some conjecture theory that it helps with neuritis, kind of post RF neuritis. So that's an option as well.
Beautiful. Thank you so much, Dr. Blake.
Yeah. So as we journey down lower in the neck for these pictures, and again, I think the value in these is the target levels and the placement of the needles. These are going to be very similar in all of the RF that you've been exposed to, where your target is at that waist with the target for the centroid of the articular pillar. And I think the value in this is just seeing the lots of different pictures to gain comfort with seeing Nimbus. You know, in this case, the contralateral oblique, you can see it on lamina. I'd accept my needles as long as they were solidly on os anywhere in this centroid on the contralateral oblique from, you know, just, I wouldn't want it off in the air, obviously. The other notable piece is testing. So much like COOLIEF, sensory testing for with Nimbus is really not necessary because of the size of the lesion. I do always do motor stimulation and look for no radicular response at 2 Hertz frequency And I actually use up to 2 volts rather than up to 1.5 volts, but anywhere between 1.5 and 2 volts would be acceptable. A few more pictures of our tines deployed and the different anatomical variants of how our articular pillars look. I'll also note that when I do my Nimbus cervical RFA, I tend to anesthetize after testing with 1 to 2 milliliters of lidocaine, and I have my staff set a timer for 2 minutes so that their discomfort is minimized as much as possible. I don't have anesthesia usually for my radiofrequency ablation other than just a Versed or Valium in some cases. And so I like to make sure that that local anesthetic has had ample time to work prior to starting my burn, and that significantly improves, especially with these large volume procedures, patient comfort. Notable also, if you are using injection with local anesthetic, the needle will only allow the local anesthetic to be delivered when the tines are deployed. When you unscrew the tines, it'll leak out the top. So I tend to deposit, if I do steroid or if I'm doing local anesthetic through the needle, I'll deposit it and then I will unscrew the needle and withdraw it. But you can withdraw this needle fully deployed. Just a few more pictures of our cervical RF and needle placement in different patients. For our C7T1, I think we were talking before about thoracic. You can see here how I orient my thoracic RF leads. I will orient them so that they that the tines are deployed kind of, I guess, in the plane of where the nerve might be, just off of that superior lateral portion of the transverse process. And I will, depending upon the patient anatomy or how I've walked off the bone, I will rotate them in either direction, either with them up with the white bevel facing cephalad or with the white bevel facing caudad. Just depends on what my pictures look like, but I kind of want them to look much like this, where they're hugging that region just superior to the superior lateral border of the transverse process. Here's another picture from the lateral where in this case, you know, we're at C6 and then at the T1, you'll note your lateral, because the transverse process anatomy will be more posterior. Here's another view. Again, same technique in terms of the lesion cycle, the lesion temperature, and all for these. Here's a couple more views. And here we move into the thoracic RF with a picture, of course, of the target for our medial branches of the thoracic levels, and of course, the areas where they tend to innervate. I tend to use my thoracic transverse process as my target, and I walk off of it. If I know that I'm solidly on that transverse process, then I know that I am in a safe location and not at risk for puncturing lungs. You know, obviously, that's kind of the most intimidating side effect to me, at least, of doing thoracic RFA is the risk of, you know, you have poor visibility due to the lung fields and due to the rib structures. So getting that really good, best view you can of a transverse process is obviously a value. Some of the tips that I found to see that transverse process over the years, doing like a Pinocchio view, or, you know, for lack of a better term, ipsilateral oblique view via live. And sometimes you'll see that transverse process kind of stick out like a nose as you rotate, and you can follow that curvature. Sometimes also adjusting your anterior, posterior, your superior and inferior, making sure your end plates are nice and square really helps pop that transverse process out so that you have more clarity of it. This is an example of the Pinocchio view where you can see that transverse process at each level projecting upwards versus the anterior posterior views of those. Patient positioning, much the same as our lumbar. I tend to put a little bit of a pillow build up underneath the kind of thoracolumbar junction just to kind of keep the patient supported. And then the process of the lesion creation is the same: placement of the needles, deployment of the tines, anesthetizing after testing, and then a similar lesion cycle to our traditional RF. Here are a few more pictures just of the placement of the needles in thoracic, and this is rotationally sometimes a challenge. So, in this case, I'm not sure. I don't think that these are the same patients, but there was some rotation, and so it looks a little anterior. When you really rotate those and get the lung fields lined up, you'll see them behind that the ZP junction. Here are a few more pictures with the tines deployed, and also these have the cannula in them. So then going on to lumbar, this is usually the most clear angle. So to discuss the perpendicular nature of the placement, rather than trying to finick a needle up and that superior articular and transverse process junction and try and get that needle parallel to the nerve target, as we need to with conventional radiofrequency ablation cannulas, you can be perpendicular. I even place these with an AP approach in certain patients if the disc prosthetic may obscure the target with rotation, but the placement is to make those perpendicular. I tend to, again, face my white marking on the needle towards the body, towards the midline, to maximize the shape of the lesion. And again, in the lateral, you see, all behind your facet lines. Again, doing motor testing up to 2 volts to rule out any radicular recruitment. And then your heat lesion of 80 degrees Celsius for 80 to 90 seconds.
Can I ask a quick question on that slide, actually?
Absolutely.
You can go back one. There you go. That middle one, the L4 medial branch there, in terms of and I've had this sometimes on lateral views when I use Nimbus, like that one's kind of, low on the facet versus the other two are kind of right in the middle of the, if you're thinking kind of just anterior to posterior, like that junction, the top and bottom are right in the middle versus the middle one's kind of real low on it. Does that matter? Do you want to be right in the middle of the joint like you are on the top and on your L3 and L5 dorsal primary ramus there, or would you reposition that L4, or is it acceptable kind of down low like that?
So I would say that the positioning really depends on the multiple views, right? So the magic would be to see that anterior, posterior, the AP picture. I also noticed here that there's just a little bit of listhesis of L4 relative to L5 and S1. So I don't know if that has to play into that somewhat. I would not reposition this needle based upon this image alone. I would take it in terms of the sum of what the motor response was. Was I getting good multifidus activation? What does the AP look like? Where is it looking on the pillar? Rather than rely on this solely.
Gotcha. Thanks.
Our target for our L5 dorsal ramus and this ala of the sacral region, this is also a nice target because sometimes these nerves are pretty large. And that's why with our sacroiliac joint radiofrequency ablation, a lot of times people will miss and not do this upper portion of the sacroiliac and get inadequate superior portion of their sacroiliac joint RF. But you can see the tines. My preference would be to have the tines fully overlying os or perpendicular to that ala. This, how it's kind of projecting up, I would probably reposition that. But again, depending upon my lateral view and my stimulation when I did my motor stimulation.
One other quick question. Sorry to keep interrupting you.
Oh, you're
In
fine.
terms of the oblique, typically with traditional RF, a parallel approach, oblique maybe 10, 15 degrees off. With the Nimbus, since it is kind of coming in perpendicular in the lumbar, I've been obliquing quite a bit, like 25, 30 degrees even, to come right at the os. How much do you oblique out on your oblique view for a down the beam view? How much are you obliquing when you're placing it? Are you going way out oblique or a little
do
bit?
based on the anatomy. So I always hate the degrees because obviously that differs depending on the patient's anatomy. But I try and bring my ear, probably between 1/3 and 1/2 of the way across the vertebral body for my oblique. But honestly, these needles, your amount of oblique matters much less. You can place these needles with an AP approach. You don't need to even oblique at all. And it, like if you were to place a needle, here and then verify, sometimes I'll verify that placement with an oblique too. And then, but when I'm doing my x-ray, I'll take a quick oblique picture and then I'll go lateral as well. But if I'm getting good stimulation and I've approached anterior, a lot of patients that have, one of the surgeons that refers to me will do multi-level disc replacements in the lumbar spine. And then they'll also have me treat their facets. Well, when you oblique at all, those disc replacements, they'll obscure your super articulating process. They'll obscure that view completely if your end plates are square. And so, I frequently actually have adopted just putting my needles anterior, like from an AP view, just
Got it.
perpendicular down the beam.
Very quickly, Dr. Blake, if you go back one slide, just one more slide back. When the tines are not on the os, I generally feel quite worried about the bones not in the background to hold the lesion. Is that a fair concern?
So, and if you think about this anatomically, this particular needle, is angled quite a bit this way. And so depending upon where those tines are rotated, if the white, say in this case is facing up, kind of to cephalad, but this needle is very, very sloped. So the fact that it's doesn't appear to be overlying the os, if it feels firmly grounded on the os, it could be just a anomaly. But your tines, if they're rotated like away from the person's body, like upwards, they're just going to be in that like in the muscular kind of like like periosteal area. Anyway, there's nothing that they're going to project into. Again, that's why I would sum my tactile feeling of like what it felt like when I landed and when I deployed those tines, as well as my lateral pictures to see what my depth is. But that shading, and then of course with my testing, that shading, it really could just be due to the fact that this needle is coming in at such a steep angle. And then when those are deployed, but with COOLIEF, I would be very concerned about this because there's forward projection that I don't have any control over. In this case, I know that my lesion is going to stay contained within this region of where the tines are. It's not going to forward project in an unpredictable direction further than that. Does that answer your question?
Yes, it does. Thank you.
But there's just so many like variables with what that means here. I wouldn't necessarily, again, throw that out. I think that's the end of my slides. We have about 10 minutes left, but I'm available longer if anyone has questions. I'm happy to answer any questions or talk about my experiences. Feel free to fire away.
In the AP or the oblique view, is it beneficial to get a nice crisp end plate and then just go for a gun barrel view?
I generally, yes. I think if you're using your needles from an AP approach, that you're best off squaring up those end plates as much as you can. So like if this particular picture is for that sacroiliac, like I would square these up more if I was targeting up here.
Okay. And how about if you're going for a more oblique approach? Is it still good to get the end plates crisp?
I think that's always, from a technical perspective, optimal. If that's always how I start with my X-ray images with my AP is I'll square up the end plates as much as possible before rotating.
Okay.
But again, due to the geometry of this lesion, I think that that's how you get the best views. It's not necessarily about the geometry of this lesion, if you have patients with substandard anatomy where that is difficult or challenging to get the best view you can, I don't think that it will alter your results that much.
Okay. And the utility of still doing a little bit inferior to superior, like,
I think that from a technical standpoint, that's just my, like how, you know, my hand and eye tends to approach. In this case, this is coming down from, you know, kind of a little bit superior, inferior, you know, as opposed to that. This may have been one that was placed, truly anterior, posterior. You know, I tend
but
to,
on that one, it seems like you're coming from superior to inferior.
correct.
Then that picture of the sacroala, where it looks like you're going very inferior to superior,
Yeah, and I don't know, so
like
this,
that one.
correct. And I don't know the circumstances around that picture, you know, I think many of these pictures are my own. I don't know about that one, but the like why this is coming up at such a steep angle. In general, most of my needles will look like this, very much kind of gun barrel view.
Okay, thanks.
So I don't know whether for a different level, just in terms of trying to square up the end plates, if that angle was changed and then the view was changed, you know, in terms of this picture.
Just limiting ourselves to lumbar RF, on an oblique view, would you be advancing just to the center of the clock face, the center of the pedicle, or would you be advancing at the leading edge, like in this picture here?
I go towards that leading edge, but anywhere between the midline and that leading edge is fine. You just want to be very careful that you haven't slipped over. You know, as you know, so again, kind of the sum of all of the, when your needle lands down, you know, what is the tactile feeling of deploying the end plates? If my nimbus needle doesn't push backwards when I deploy the lesion, I don't have faith that my tines are solidly on os. And I will reposition usually in that case too. I want them to be on os.
Great point. And just looking at thoracic anatomy, the landmarks are different depending on the level we're treating. If you can please run us through the thoracic anatomy here.
Yeah, so going back to the picture of where these joints and looking specifically over on this right side of the screen, if I can maybe zoom into that, it slightly moves, but in general, using the target of your transverse process here and going up to that lateral edge, you will generally address it. Like I don't usually, like for instance here, which this is probably 11, 12, like T6, T7. I don't generally place my needle without a bony landmark underneath it. So I would, for this particular level, I would drop down to my superior lateral view, and then I would use my tines to direct superiorly once I walked off the leading edge of that superior lateral location. But in general, the target is always going to be that superior lateral transverse process, just above it, just superior to it.
Excellent. Thank you.
Just had a quick question going back to cervical.
Yeah.
I know you had a disclaimer with Coolleaf and with the traditional that you never did a lateral approach, but can you clarify or just reiterate why that would be contraindicated, I guess, with the nimbus approach? Because with the lumbar, you're saying, you know, you can almost go AP as long as you get those tines to touch down.
Correct.
Get near there, you could get a, you know, it may not be the perfect pear-shaped burn, but you'll get at least 10 millimeters. So what's the problem going lateral with nimbus in cervical?
That's a very good question. And I'm not so sure that there is any specific contraindication from approaching lateral, except for, from my perspective, and just for clarity, was your baseline training anesthesia or physiatry?
Physiatry.
Okay. So my experience just in observing, like teaching Coolleaf through the years, is that the majority of people who are doing the lateral approach with radiofrequency ablation have physiatry background. So just as a like anchoring point of that, is that that there is going to be some comfort because that's how you trained. And that seems to be very common among physiatry trained pain physicians. My introduction to the lateral approach was actually as a speaker for Avanos, where I had never been introduced to it until Avanos. But Avanos was necessary to use the lateral, they during their safety, as Avanos rolled out more in practice and in the hands of physicians, kind of boots on the ground, it became necessary for us to teach the lateral approach with COOLIEF because of the forward projection and because people were getting into trouble with poorly placed lateral images, so to speak, where people were, the forward projection with COOLIEF was less controlled. And so they were having issues when people were placing their needles too deeply, and then there was forward projection in tissues that they couldn't control. And so they adopted the lateral approach where the patient's laying on their side and then dropping down onto the articular pillar to help and decrease the risk associated with COOLIEF. So I guess that it's more that it's not necessary to do that approach. I think that in general, the Nimbus trainers, because every device, as you know, has to go through FDA kind of clearing. And so the cleared and FDA recommended process of placement of Nimbus is to use it with the anterior posterior approach. But that's also because it has never been necessary to change the approach to recommend the lateral approach. This is an approach that optimizes that area. I will agree with you logically. If you are placing your tines so that they are oriented, superior and inferior, and you are placing your needle in the kind of centroid or second, third to the posterior side of centroid on the lateral view, if that makes sense. I think that you would be safe to proceed in that way, but that's just not the FDA kind of certified approach. If that answers your question.
I will
Yes.
say, it
Yeah.
might be going forward in terms of I've been in practice for 16 years, and I've always done cervical RF from a posterior approach in a prone position like that. But I've taken the SIS cervical cadaver lab several times just to, as a refresher. And I did it recently, last year, and they were teaching at the cadaver labs doing medial branch blocks in a lateral approach. And so it might be starting to be used a little more. Their proponent of it was that it's more comfortable to do it in a lateral approach for patients because there's less tissue you're going through, and then just going right at the waist of the articular pillar. But the reason I had not really done it in the past is because if you don't have a perfect lateral and things aren't lined up well, and you don't go back to your AP early enough, you could potentially end up in the spinal canal if you're looking at the wrong side facet joint and then you push too deep without checking. But I know they are teaching medial branch blocks in a lateral approach more now, and not really pushing for it, but kind of pushing that forward as their main way of doing it. So there might be more people who are comfortable with that lateral approach, in the future.
It's interesting because I've heard that said before, that it's more comfortable for patients. My dissent to that is I have never, ever had a patient more comfortable with me leaning over their face, which is necessary if you're doing that lateral approach. So it's one of those things that I've been fascinated about that shift, but I do know internally the reason why the teaching of Avanos was shifted in that way was due to the concern of the forward projection of the cannula in people that were not otherwise comfortable with the anterior posterior approach or posterior to anterior approach. But I do find it interesting if SIS is teaching it. They had a trainer probably that really likes it. I find it fascinating because I don't particularly like that approach at all in terms of my own hands-on practice. But likewise, I empathize if if one doesn't really love the approach from the posterior perspective. And especially now with insurance is more and more requiring you to do both sides at the same time. The logistics of having a patient that maybe has some Valium on board or, you know, is a little bit sedated, of having to actually like physically get up and turn over so that you can do the other side during an RF, just, it's never made sense to me, just as my own aside. Does anyone else have any questions or more things to dive into?
I have a question. This is Wes Wiltsey from Kaiser in California. I thank you for the talk. I tuned in late because I was with patients, but you might have talked about this at the beginning. How exactly does the lesion work? That's the part I'm not familiar with. This is my first time hearing about Nimbus. And then the other question is, are the electrodes disposable? Are they reusable? What is the, you know, from a cost standpoint, I'm curious.
Sure. So first, your second question is, so these are needles, you know, they're the introducer cannulas. The probes, you can use whatever probes that you have. These needles are compatible with, as far as I'm aware, unless there's been a new machine that I don't know about, they're compatible with every machine on the market and with all the probes. I use a mixture of reusable probes, and I have, but mostly use disposable probes. That's just based upon the preferences of my surgical center. But they can be used with the probes that you have and with the machines that you have. The anatomy of Nimbus, so to speak, is that you have your traditional introducer that is attached to a spin collar that deploys stainless steel tines in this kind of Y configuration. And so these tines are stainless steel, whereas in some of the other kind of large volume needles that are on the market, they'll use nitinol or something that's less structurally secure than stainless steel. So these tines are actually strong enough when you are in seated on os with the cannula, they will actually push back usually on os. They'll push you away so that there is no, it doesn't, you know, forward project, except for when you purposefully try and project it forward. And so the volume of this lesion ends up being about 601 millimeters cubed. It's a pear-shaped lesion, so it's maximized by the breadth of the stainless steel tines. There's a little directional component of those tines. They kind of project towards the bevel, which is marked by the white line on the introducer hub, or I'm sorry, on the cannula, well, in the introducer cannula hub. And that white line signifies which direction these tines will kind of project slightly in front of the needle. And so that creates this pear-shaped lesion that is largest at its base. So showing from a different perspective, you have traditional cannula that requires parallel placement because it's taking advantage of the 10 millimeter active tip. And you try and create it parallel so that you can create the largest lesion along the target, as opposed to these needles provide an exceptional lesion when placed perpendicular to the target. They'll also produce a good lesion when you're parallel too. It's just that you can place them perpendicular, and that's really the preferred approach in terms of just safety and just ease of technique. And so since we're revisiting this piece, like places that I have found that very useful are in places such as necks where their anatomy is not perfect, where they have lots of bony overgrowth and kind of callus to get through to get to that centroid or that perfect waist of the pillar. Patients that have disc replacements in the lumbar spine, where when you oblique to try and get that good parallel placement, you end up obscuring your view, essentially. Sometimes if you're using RF in an area where it's just harder to access due to maybe like, maybe you have an IPG generator that's in the way, or stimulator leads that you need to kind of navigate around. This allows you to place your needle regardless of how you have to rotate your fluoroscope to get the view.
I had one one question on, I had a rep tell me when I first started using Nimbus that if you retract the tine while the probe is still in the needle, that it can get stuck. And like if I'm repositioning, I've generally, if the probe's in the needle, I've been like pulling it about halfway out so the tip of it's like well past where the tines would be inside the needle, and then withdrawing the tine so I can reposition the needle so you're not like creating a bunch of trauma trying to move it with the tines out. Can the probe get stuck in the needle if you retract the tines with the probe still in the needle or anything? Like, is there any risk of that?
So I would have to have the Nimbus people kind of commenting on that, because I have not had the experience of ever getting probes stuck. I have pulled the needles out, not deployed. The only thing that I really try and that you don't want to necessarily do is try and redirect the needle with the tines deployed.
Right.
Because you're trying to redirect the needle with the tines deployed, potentially you could bend the stainless steel. It's pretty durable, but that could create some tissue trauma or pain for the patients. It's not how the needle was meant to be used, was to redirect it with the tines deployed. In terms of getting the actual like radio frequency probe caught with manipulation of the tines, I have not had that occur. Is there any kind of comment from the Stratus support?
So I personally have never seen it happen. However, because Nimbus is all one piece and it's connected at this tip, they share a same channel. So the tines are in the same channel as the probe goes down. So the likelihood is very slim, but it has happened once. And so it's been reported one time. So we just like to say it as a, caution,
So do you recommend taking the probe, like just as a rep standpoint? Like I said, I kind of withdraw the probe about halfway out, which is, pulling it back several centimeters, but not all the way out of the needle. Like, do you recommend not retracting the tines with the probe in the needle at all? Or you just pull the probe up a little bit and then retract the tines like I've been doing, or?
I would personally, just because I know that it's happened one time, and for safety reasons, or the thing is if the probe does break off into the device, it's going to stay in there. It's not going to fracture off into the patient. You just chance the fact that it could possibly break. Again, I haven't seen that happen, but I always recommend to have the probe just fully out before you reposition.
Yeah, I wouldn't be too worried about breaking the tine off the probe in the patient. Is more just, like you said, wrecking your probe, which are not cheap in
Right.
terms
Yeah,
of the reusable ones.
exactly.
I'm trying now to think how I do, because frequently with cervical you do have to reposition with testing. I wouldn't say frequently, but I don't know how often I'm going to pay attention now, how often I've needed to do that. That's an interesting tidbit.
Dr. Blake, this is Chris, the Northern California rep. I was going to see if we could advance to the slide for Dr. Wiltsey, just in terms of lesion shape, showing the comparison of the spherical lesion.
Sure, for Cooley.
Yeah, right there on the right.
So the main thing to be really aware of in terms of Cooley versus Nimbus is that there is no forward projection. And so the Cooley makes a sphere-shaped lesion with about 45% of that lesion forward projecting past the needle tip, where you don't have control over its progression, essentially, as opposed to Nimbus, which your lesion is going to be contained in the general region of your tines that are created with that spread of the tines being the major feature of that bulk of lesion. Does that answer?
Thank you. Yeah, that's great. I just had no idea about Nimbus. We use CoolRF already. The fact that it can be utilized with already existing hardware is definitely a good thing within managed care. So I am curious to try this, especially since it's just a matter of getting cannulae.
So you weren't here in the beginning, but so one of my kind of history of cool leaf and large volume RF is that when I was in fellowship, my fellowship site was a site for one of the trials for cool leaf before it was on the market, and then subsequently I helped get cool RF generators in most of the hospitals here in St. Louis, and then used them, for many years and taught for Avanos and things. And as my practice kind of evolved, I'm the owner of my ASC, and I tried to use cool leaf for a little while in that space. But I've used Nimbus with my cool leaf generator, so there's certainly no issues with that at all. It is and what I had said before is when I made the transition, I had transitioned before starting to use Nimbus. I had transitioned to mostly saving cool leaf for sacroiliac joints and for thoracic, which is where I really felt that the large volume was necessary. And then when I found Nimbus, I was able to reincorporate large volume RF back into my practice again, in a way that was more kind of achievable in the surgical center setting. So I think that it's very much worth trying. I actually feel that I get better results now using Nimbus. I think that just as another tidbit, based upon like my experience of that transition, is that I tend to want with Nimbus to numb longer. So when I put my after motor testing, when I put my local anesthetic in, I tend to use like a 2% lidocaine, and I tend to set a timer for a solid 2.5 to 3 minutes, just to make sure that it's really anesthetized. I don't have patients that have any sort of deep sedation or anything on board, so I find that that's really important for patient comfort. But other than that, it's been a smooth transition. My patients really get better results, and I even now I've been using Nimbus for now a little bit over 3 years, and almost exclusively in my ASC, and the patients who have had both done will say that their length of time, like that their experience was better. And I think that there was like a day that I had run out of needles and didn't have them, and I did regular RF again on that day's patients, and they all knew the difference, both in terms of the just comparative to regular versus large. They all recognized that they didn't have as long of results as they usually did, and they recognized that the process and the procedure seemed, because it had to involve them more with the sensory testing as well, that they had to be more alert, that they kind of were less relaxed during the procedure. That there were a number of feedback items that the patients gave. My staff, if I for some reason choose to use traditional RF, they kind of groan now. They much prefer it when I use the Nimbus needles. So
Have you seen, so I've been using Nimbus pretty exclusively for, I don't know, maybe almost a year now. Before that, I was using the Stryker Venom needle to get a larger lesion. Like in terms of durability of effect, when you've kind of compare, and I've used Cool Leaf mostly for SI and like geniculate, just because in the ASC, Cool Leaf has always just been a cost. You lose money on it pretty much with their kits costs, and even Nimbus, I tend to use less needles. Like if I have a 3-level burn, I might use 1 needle and do each level individually, or do 2 levels and then do the third one with one of the 2 needles to just kind of conserve costs, because it is a good bit more expensive than the other products.
Sure.
And we own our own ASC like you, and so cost is always a concern about materials. But have you found the durability of effect to be superior, comparable, about the same to other techniques like pooled or Venom or traditional RF using 18 gauge and a couple burns? Like I haven't been using it long enough to get a good feel for my patients so far if like they're doing better than what I was doing in the past, or about the same, or like what in terms of just outcomes?
Sure. So I feel that my incidence of neuritis and cervical neck, which was never high, but in one of the attendees was asking about a patient that had a dysesthesia that had encountered you know, her in her practice. And so I found the rare dysesthesia that I would get, I don't get them as much with Nimbus. In fact, I can't think of a time that I've had a dysesthesia with Nimbus. But it was something that would rarely occur previous to that. In terms of the durability of effect, I think that there is a significant durability effect, and I'll tell you that that one of the things that I would say is I get a lot of referrals directly from spine surgeons, which I'm sure you guys do too. And I had a spine surgeon that didn't traditionally refer to me that actually completely transitioned to referring to me, because he was like, I don't understand, your patients seem to actually get better results from RF. And so he sends me all of his RFs now, rather than the other 2 or 3 doctors that are in the kind of affiliated kind of region. So, you know, I think that those are kind of results that speak for themselves. I think in studies too, I think that, and Tammy, you can correct me if I'm wrong about that, but in kind of studies that have been out, that there's evidence that the durability is longer as well, compared to the other.
Yes, absolutely. We have multiple studies where, you know, it's showing 12 months or greater. And then genicular, the newest or the most recent study is 2-year outcomes.
I'll say too, this is a good slide that we're on right now. You can, that PE, that 20 gauge PE is protruding electrode. So you can see the lesion size. So whether it's like a Boston Scientific Sidekick or a Stryker Venom, you could see you're getting 3 times the size of the lesion with Nimbus over what that PE is referring to as a protruding electrode.
It also just as an aside too, a couple times I've referred to the fact that Nimbus is made out of stainless steel, and that's necessary to point out. Like if any of you all have like nitinol probes, like the reusable probes, nitinol is a very flexible material, and so for people that like to redirect their needles when they're in the patient and things like that, which I know from training COOLIEF, one of the problems that we used to run into with training for COOLIEF was that people liked to, you know, the cannula is completely blunt, and people liked to try and redirect it. So I know that most physicians have the tendency to want to redirect their things once they're in place, without putting back a cannula or an introducer. But nitinol will shear in patients. Stainless steel, what Nimbus is made out of, the stainless steel, it won't shear. And there are case reports of the nitinol protruding electrode products shearing in patients when someone has redirected them. You know, that it's just an aside to point out as well in terms of safety, patient safety.
Okay, well, does anybody else have any other questions?
I appreciate all of your engagement. I have to say, I've given a bunch of Zoom talks, and this has been really one of the more engaged groups, and I really appreciate that.
Thank you.
Yeah,
Thanks, Dr. Blake.
Thank you.
Appreciate it.
Thank you very much.
Thank you very much.
Yeah, thank you.
Thank you.